Hello guys, this is me Dr. JK, and today we will discuss about dentigerous cyst. In our previous lecture we have studied about odontogenic keratocyst, and today we will discuss about dentigerous cyst. Dentigerous cysts are also known as the follicular cysts. Okay, it originates by the separation of the follicle from around the crown of an unerupted tooth. It is most common type of developmental odontogenic cyst. This is very important point. Okay, it comprises 20% of all epithelium lined cysts of the jaws. The dentigerous cyst encloses the crown of an unerupted tooth and is attached to the tooth at the cemento-enamel junction. This is the image which shows the maxillary canine, and this is the dentigerous cyst, and it is present over this tooth, and it is attached to the this tooth at the cemento-enamel junction. If we talk about pathogenesis, then it is uncertain, but apparently it develops by accumulation of fluid between the reduced enamel epithelium and the tooth crown. If we talk about pathogenesis, then mostly it is developmental, but in some cases it may be inflammatory. For example, it has been suggested that on occasion a dentigerous cyst may develop around the crown of an unerupted permanent tooth as a result of periapical inflammation from an overlying primary tooth. The term periodontal cyst sometimes was used for the dentigerous cyst, but it was confusing because it also has been used to describe example of what is known as the buccal bifurcation cyst. So it is better to use dentigerous cyst rather than using periodontal cyst. And now we'll discuss about clinical features. It is most commonly present at the mandibular third molar area, and other sites include maxillary canines, maxillary third molars, and mandibular second premolars. Dentigerous cysts rarely involve unerupted deciduous teeth. It is again a very important point. Okay, occasionally they are associated with supernumerary teeth or odontomas. It is most commonly present in the patients who are 10 and 30 years of age, most commonly present in white males. Okay, if we talk about smaller lesions, then it will be completely asymptomatic and are discovered only on routine radiographic examination or when films are taken to determine the reason for the failure of tooth to erupt. Dentigerous cyst can grow to a considerable size, and a large cyst may be associated with a painless expansion of the bone in the involved area. If we talk about the lesion to be extensive, then it will cause facial asymmetry. If we talk about large dentigerous cysts, then they are uncommon. And most lesions that are considered to be a large dentigerous cyst on the radiographic examination will prove to be odontogenic keratocyst or amyloblastoma. So whenever you suspect large dentigerous cyst on the basis of the radiograph, then you might be wrong. That might be odontogenic keratocyst or amyloblastoma. That is because large dentigerous cysts are uncommon. Okay, and if they are infected, then they may be associated with pain and swelling. Such infections may arise in dentigerous cyst that is associated with a partially erupted tooth, or by extension from a periapical or periodontal lesion that affects an adjacent tooth. Now we will discuss about radiographic features. It will be unilocular radiolucent area that is associated with the crown of an unerupted tooth. A well-defined and often sclerotic border will be there, and if it is infected, then it may show ill-defined borders. Okay, and if the cyst is larger in size, then it may show multilocular process because of the persistence of the bone trabeculi within radiolucency. Dentigerous cysts, however, are grossly and histopathologically unilocular processes and probably never are truly multilocular lesions. So they are most commonly unilocular processes rather than to be multilocular lesions. And if we talk about the radiographic variations, it may be central variety, lateral variety, and circumferential variety. And first of all, we will discuss about central variety. It is the most common radiographic relationship. It develops around and surrounds the entire crown of the tooth. Thus, tooth appears to be erupting into the cyst. Here we can see this is the impacted mandibular second molar, and this is the radiolucency present over the crown of the tooth. And it looks like the tooth will erupt inside the cyst cavity. Here you can see it is attached at the cemento-enamel junction. And the second variety is lateral variety. It develops at the lateral tooth root and only partially surrounds the crown. Here you can see this is the mandibular third molar, which is impacted, and the cyst is present, very large cyst here. Okay, and it is present at the lateral surface of the tooth, and here you can see, and it partially surrounds the crown. The third one is the circumferential. It develops around the crown and extends down the root or roots. These roots also appear within the cyst. This is the third one. Here you can see it surrounds the crown as well as the roots, and here you can see this is the radiolucency. Okay, one thing that is common in all these three radiographs is that all three teeth are impacted. This is somewhat distoangular impaction, this is mesoangular, and this is vertical, or you can say mesoangular impaction. Okay, if you talk about dentigerous cysts, they are most commonly unilateral, and bilateral dentigerous cysts are uncommon. For the lesion to be considered a dentigerous cyst, some investigators believe that the radiolucent space surrounding the tooth crown should be at least 3 to 4 millimeter in diameter. This point is very important. Okay, so if the radiolucent space surrounding the tooth crown is less than 3 millimeter, then it means that it is most probably follicle, and if it is larger than 3 millimeter, then it is most probably the dentigerous cyst. So the radiolucent space will decide whether it is the follicle or the dentigerous cyst, the size of radiolucent space. Okay, you should memorize this figure, 3 millimeter. Okay, if we talk about histopathological features, there are some varieties as far as the histopathological features are concerned, and they are dependent on whether the cyst is inflamed or not inflamed. If they are not inflamed, then the fibrous connective tissue wall is loosely arranged and contains considerable glycosaminoglycan ground substance. Small island or cords of inactive appearing odontogenic epithelial rests may be present in the fibrous wall. Occasionally these rests may be numerous, and at times pathologists who are not familiar with oral lesions have misinterpreted this finding as amyloblastoma. In the non-inflamed type, thin flattened epithelial lining, which is 2 to 4 cell layer thick with connective tissue wall, is seen. If you talk about odontogenic keratocysts, then they are 6 to 8 cells thick, and here we have 2 to 4 cells thick. If you talk about inflamed cysts, then the fibrous wall is more collagenized with a variable infiltration of chronic inflammatory cells. The epithelial lining may show varying amounts of hyperplasia with the development of ratty ridges and more definite squamous features. Focal areas of mucous cells may be found in the epithelial lining of dentigerous cysts. Gross examination of the wall of the dentigerous cyst may reveal one or several areas of nodular thickening or on the luminal surface. This point is very important as far as the neoplastic change is concerned. Okay, these areas must be examined macroscopically to rule out the presence of early neoplastic change. If we talk about aspiration, if you aspirate the cyst, then it will lead still thin watery yellow straw color fluid, and if you talk about the odontogenic keratocyst, that will lead creamy whitish and odorless fluid, and here it is thin watery yellow straw color fluid. And if you talk about differential diagnosis, then it may be unicystic amyloblastoma, odontogenic keratocyst, bilateral buccal bifurcation cyst, enlarged dental follicle, multiple hyperplastic calcifying follicles. These are the differential diagnoses as far as the dentigerous cyst is concerned. If you talk about treatment, then treatment varies on the basis of age, maturity, anatomic position, and the relative importance of tooth involved, size of the cyst, presence of additional neoplasm, also patient preference, including cosmetic and function consideration. Enucleation of the entire cyst with extraction of the associated tooth is most common approach, and it is a preferred approach. Okay, because if we do marsupialization, that is the removal of the cyst sparing the permanent tooth, then the recurrence chances are there alongside the marsupialization, and we do enucleation of the entire cyst with extraction of the tooth. Okay, and also the marsupialization will require follow-up to monitor the recurrence. Okay, and if you talk about prognosis, then it is excellent, almost never reoccur with complete enucleation. However, follow-up radiographic studies recommended. If there is recurrence, that it means that it was incompletely excised or incorrect original diagnosis was made at the time of diagnosis. Tooth sparing marsupialization procedure may have higher risk of cyst recurrence or persistence. That is why we use enucleation more commonly than marsupialization. And if here we have, if we talk about the second neoplasm, that is rare, as far as the dentigerous cyst is concerned. But if they are present, then they will most commonly be amyloblastoma, squamous cell carcinoma, and intraosseous mucoepidermoid carcinoma. Okay, second neoplasm can be there, but they are rare. Okay, and if they are present, they may be ameloblastoma, squamous cell carcinoma, and intraosseous mucoepidermoid carcinoma. This is the salivary gland tumor, malignant. Okay, so these are the references of this lecture. Hopefully you enjoyed my lecture. If you enjoy my lecture, please subscribe to my channel. Till my next lecture, take care and bye bye.